Before we begin this journey through the medical chain that held the British assault brigades together from Normandy to the Rhine, if you value stories that dig into the mechanisms, the people, and the impossible choices that defined the Second World War, hit that subscribe button now. This channel exists to bring you the untold logistics, the human cost, and the brilliance buried in the archives, and your subscription keeps these stories alive. June 17, 1944, somewhere south of Tilly-sur-Seulles, in the Norman Bocage. The hedgerows are thick as castle walls, each one a fortress of root and thorn. Mortars thump in the middle distance, their detonations brief and flat, swallowed by the earth and the grain. A rifle company from the 59th Division is pinned in a sunken lane, 200 yards from an objective they will not reach today. The Spandau fire comes in short, disciplined bursts, traversing the lip of the lane, and when it stops for a moment the men hear something worse. A voice calling for a medic, high and insistent, then fading into something closer to a sob. The voice belongs to Rifleman Thomas Harper, 22 years old, from Middlesbrough. A fragment from the last mortar strike has torn through his left thigh, shattering the femur midshaft and opening the femoral vessels. He is bleeding into the dirt of Normandy, and without intervention, he will be dead in minutes. Two stretcher-bearers, part of the regimental aid post detachment, crawl forward under the sporadic fire. They are not combatants, though they carry no weapons, and their armbands bear the Red Cross on white. The Spandau does not always respect that distinction. One bearer's name is Corporal Winters, the other Private Dalton, and they have done this 6 times already today. They reach Harper in the ditch where he has rolled, his battle dress soaked dark from groin to knee. Winters presses a field dressing hard against the wound, but the blood wells up too fast, pulsing with each heartbeat. Dalton, hands shaking, fumbles a tourniquet from his haversack, a length of rubber tubing and a wooden toggle. He slides it high on the thigh, just below the groin, and twists. The bleeding slows, then stops. Harper screams once, then goes quiet, his face gray. Winters pulls a morphia syringe from his webbing, a small tube with an attached needle, twists off the cap, and drives it into Harper's upper arm through the sleeve. He pins the empty tube to Harper's collar, so the next man in the chain will know the dose and the time. They drag him onto a folding stretcher, canvas and wood, and begin the low crawl back toward the lane junction, where the regimental aid post is dug in beneath a hedgerow and a tarpaulin. The Rap is now a hospital. It is a hole in the ground with a medical officer, a sergeant, 2 orderlies, and a collection of dressings, splints, and ampoules that would fit in a pair of panniers. Captain Lawson, the M.O., is a general practitioner from Exeter who 6 months ago was treating flu and broken fingers. Now he is conducting triage under shell fire with the noise of small arms, so close that dirt falls from the tarp roof with every burst. Harper is carried in and laid on the grass beside 3 other wounded, one with a sucking chest wound who is breathing in wet, rapid gasps, another with a mangled hand wrapped in a bloody rag, a third unconscious with a head injury and a slow trickle of clear fluid from his nose. Lawson moves between them with the speed of long practice, checking pulses, lifting eyelids, reading the morphia tabs pinned to collars. He kneels beside Harper, cuts away the trouser leg with scissors, and examines the tourniquet. The leg below the rubber tube is pale and cold, no pulse at the ankle. Lawson knows the clock is running. A tourniquet can save a life in the first hour, but after 2 or 3 the limb begins to die from ischemia, and after 4 the toxins from dying muscle can poison the whole body when the tourniquet is released. He writes on a triage card in pencil, femoral fracture, major hemorrhage controlled, morphia 1/16 grain, priority immediate evacuation. He ties the card to Harper's wrist, sprinkles sulfa powder into the wound to prevent infection, and applies a fresh shell dressing, firm but not crushing. Then he calls for the jeep. The jeep is a Willys, olive drab and anonymous, fitted with stretcher racks welded to the sides. It is parked 50 yards back in a sunken track, engine idling, driven by Private McKay, a dispatch rider turned ambulance hand. Lawson and the orderlies carry Harper and the chest wound case to the jeep, strap them in, and McKay pulls away, bouncing over ruts and shell craters, navigating by memory and a scribbled map. The advanced dressing station is 2 miles back, set up in a farmhouse cellar, with stone walls thick enough to stop shrapnel. McKay drives without lights, though it is still afternoon, because the Luftwaffe has been strafing the roads at dusk. He passes a column of Shermans moving up, their tracks clanking and grinding, and a company of infantrymen marching in single file along the verge, faces blank with exhaustion. No one looks at the jeep. Wounded are routine. The ADS is busier than the RAP, a controlled chaos of movement and voices. There are 3 medical officers here, 2 surgical teams rotating through, and a dozen orderlies and nursing orderlies. The cellar smells of blood, antiseptic, sweat, and the latrine buckets in the corner. A trestle table serves as an operating surface, lit by a hissing pressure lantern. Harper is carried down the stone steps and laid on the floor among a dozen others. A captain with a stethoscope and a tired face moves among them, retriaging, checking labels, making marks on cards. He stops at Harper, reads Lawson's note, checks the tourniquet time. 2 hours now. He nods, writes priority 1, and waves for the orderlies. Harper is moved to the table. The surgeon, Major Calloway, a man who once lectured at Guy's Hospital and now works in a cellar, cuts away the rest of the dressing and examines the fracture. The bone ends are visible, pale spikes through torn muscle. The vessels are retracted into the thigh, hidden. Calloway cannot do a full repair here, but he can stabilize. He calls for a Thomas splint, a metal frame with a padded ring at the top and traction cords at the bottom, designed to immobilize a broken femur and reduce the fracture. 2 orderlies hold Harper's leg, while Calloway slides the ring under the buttock and extends the leg, pulling gently to align the bone. Harper, half-conscious, groans. The splint is strapped in place, the tourniquet loosened gradually, and the wound packed with more sulfa and gauze. Calloway starts an intravenous line, a rubber tube and a glass bottle of plasma, the yellowish fluid that can replace lost blood volume without the complications of whole blood transfusion. The plasma runs in slowly, dripping through a needle in Harper's forearm. Calloway writes on the card, Thomas splint applied, plasma 500 cc. No hemorrhage on release. Transfer to MDS for surgery. Harper is carried back to a corner to wait for the next ambulance run. The main dressing station is 5 miles further back, near the village of Bayou, in a cluster of tents and requisitioned barns behind a stone wall. It is a semi-mobile surgical hospital with X-ray capacity, a proper operating theater under canvas, and a holding area for up to 100 casualties. Harper arrives by ambulance, an Austin K23-tonner with a canvas top and a red cross painted on the sides, driven by a woman of the Fanny, the First Aid Nursing Yeomanry, a volunteer corps attached to the RAMC. Her name is Margaret Holt, and she has been driving wounded for 18 hours straight, her hands cramped on the wheel, her eyes burning. She backs the ambulance up to the receiving tent, and orderlies unload Harper and 5 others. The MDS is organized by function, reception and triage, resuscitation, X-ray, surgery, post-operative holding, and evacuation prep. Harper is carried to the X-ray tent, where a portable machine on a wheeled cart is operated by a sergeant technician. The plate shows the fracture clearly, a transverse break with displacement and comminution, small fragments of bone scattered in the soft tissue. The surgeon on duty, Lieutenant Colonel Fenton, reviews the plate and decides, debridement and external fixation tonight. Definitive repair later if infection does not set in. Harper is taken to the surgical tent, a double-walled canvas structure with a wooden floor and a stove in the corner for sterilization. The operating table is a folding metal frame with a rubber mat. Above it hang 2 more pressure lanterns and a surgical light running off a portable generator that rumbles outside. An anesthetist, Captain Morris, induces Harper with ether dripped onto a gauze mask, counting him down through the stages until his breathing is deep and regular. Fenton, gowned and gloved, scrubs his hands in a basin of hot water and carbolic, then steps to the table. The wound is already open, so he extends the incision, cutting through skin and fascia to expose the full length of the fracture. He removes the loose bone fragments, irrigates the wound with saline, and debrides the torn muscle, cutting away tissue that is already turning gray and necrotic. He checks the femoral artery, finds it intact but bruised, and leaves it alone. The vein is torn but clotted. He ligates the bleeding vessels with catgut, packs the wound with gauze soaked in antiseptic, and decides not to close the skin. Open wounds drain better, reducing the risk of gas gangrene, the anaerobic infection that can kill in hours. He applies a light dressing and writes orders for penicillin, the new antibiotic that has just begun arriving in theater in small, precious quantities. Harper will receive 20,000 units intramuscularly every 3 hours for 5 days if supply holds. He also orders anti-tetanus serum and notes that the patient will need reevaluation in 48 hours and probable secondary closure if the wound remains clean. Harper is moved to the postoperative tent, a long ward under canvas with folding cots arranged in rows. The nursing staff here are QIMNS, Queen Alexandra's Imperial Military Nursing Service, and VADs, Voluntary Aid Detachment, women in khaki dresses and white aprons who work 12-hour shifts in the heat and the flies and the smell of wounds. Sister Emily Bradshaw, a nurse from Manchester, checks Harper's pulse and respirations every 15 minutes, records his intake and output, and watches for signs of shock or hemorrhage. The penicillin injections are given on schedule, each dose drawn from a small vial and delivered into the muscle of the buttock or thigh. The drug is still experimental in field use, its production ramped up only in the past year, but the results are remarkable. Wounds that would have suppurated and killed now begin to heal. Harper's fever, which spiked to 102 degrees Fahrenheit on the second day, drops back to normal by the third. His wound, inspected daily, shows no spreading redness, no foul odor, no crepitus under the skin. On the 5th day, Fenton returns to the bedside, examines the wound, and decides to close. Harper is taken back to surgery, anesthetized again, and the wound edges are brought together with interrupted sutures. The Thomas splint remains in place, and he is told he will be evacuated to England within the week. But Harper's case is one among thousands, and to understand the full scope of the Ramp's work in 1944 and 45, we must follow the system as it stretches and bends under the weight of the great offensives. In late July, Operation Bluecoat sends 3 British corps south and east from Calmont toward Vire, aiming to unhinge the German front before the American breakout at St. Lo. The assault brigades go forward in the dawn, through hedgerows and hidden at guns, and the casualty rate climbs within the first hour. The Raps are overwhelmed, each one receiving 40, 50, 60 wounded in the space of a morning. The MOs and orderlies work without pause, triaging in the open because the aid posts are full, laying men on the grass, on stretchers, on ground sheets. The categories are immediate, urgent, delayed, and expectant. Immediate means life-threatening injuries that can be saved with rapid surgery. Hemorrhage, chest wounds, abdominal trauma. Urgent means serious but stable, can wait a few hours. Delayed means walking wounded, minor fractures, soft tissue injuries. Expectant means dying, beyond the capacity of the system to save, receiving morphia and comfort and nothing more. It is the hardest decision an MO makes, and some never forgive themselves for it. But in the calculus of mass casualty, it is the decision that saves the most lives overall. The chain backs up. The jeeps and ambulances cannot keep pace with the inflow. The ADS receives 100 casualties in 3 hours and runs out of plasma by midday. A motorcycle dispatch rider is sent racing back to the MDS with a requisition, and a lorry returns with crates of plasma bottles and cartons of whole blood, type O, stored in ice chests and flown in from England that morning. The blood transfusion service is a marvel of logistics. Donors in Britain, collection in sterile bottles with citrate to prevent clotting, refrigerated transport by air to Normandy, and distribution to forward surgical units within 24 hours. The blood arrives cold, and the orderlies warm the bottles and basins of hot water before transfusion. A soldier with a traumatic amputation of the lower leg, bleeding controlled but shocky, receives 2 pints of whole blood through a glass drip chamber and a rubber tube, and within an hour his blood pressure stabilizes, his color returns, and he is moved to surgery. The amputation is revised, the bones sawed smooth, the muscles trimmed and sewn over the stump, and he is evacuated to the CCS the next day. The casualty clearing station is the next link, a large semi-permanent facility 10 to 15 miles behind the front, with capacity for 300 patients, full surgical theaters, radiology, pathology, and a holding ward for those too sick to travel further. The CCS near Bayou, designated number 75, is set up in a requisitioned chateau with tents in the grounds and a perimeter of barbed wire and sandbags. It receives casualties by road from the MDS and by air from forward strips where light aircraft, Osters and Piper Cubs, land on grass fields and fly out the stretcher cases who cannot wait for the ambulance queue. The surgical staff at the CCS work in shifts, 6 hours on, 6 hours off, for days at a stretch. The cases are severe, abdominal wounds with perforated intestines, requiring laparotomy and resection and colostomy. Chest wounds with collapsed lungs, requiring chest tubes and drainage. Head injuries with depressed skull fractures, requiring craniotomy and elevation of bone fragments. The anesthetists, often junior officers trained in a hurry, manage the cases with ether, chloroform, and the new agent thiopental, a barbiturate that induces unconsciousness in seconds. Some casualties arrive in extremis, blue from lack of oxygen, pulseless from blood loss, and the teams work desperately to resuscitate them, pumping blood and plasma, opening chests to massage hearts, but not all survive. The expectant cases are placed in a separate tent, quiet and dim, attended by a single nurse and a chaplain, and they die one by one through the night, their identity discs collected, and their names entered in the ledger. The pressure continues through August as the breakout becomes pursuit, and then the race to close the Falaise pocket. The REMC moves forward with the advancing divisions, RAPs and ADSs leapfrogging ahead, CCSs packing up and relocating to capture German field hospitals and requisition schools. The wounded keep coming, not just British but Canadian, Polish, French, and German prisoners. The Geneva Convention requires that enemy wounded receive the same standard of care, and they do, triaged and treated alongside Allied soldiers, though the guards remain close and the atmosphere is tense. A German paratrooper with a shattered pelvis, captured near Falaise, receives the same plasma, the same penicillin, the same surgery as the British rifleman in the next bed. The surgeons do not discuss politics or ideology. They discuss blood pressure and pulse and the color of the wound. The war is elsewhere. Here there is only tissue and bone and the effort to repair. By September, the front has moved into Belgium and the Netherlands, and the REMC faces a new challenge. Operation Market Garden, the airborne assault to seize the bridges from Eindhoven to Arnhem. The plan calls for rapid relief by ground forces, but the advance stalls, and the airborne divisions at Arnhem are cut off and besieged. The forward medical units, including the 16th Parachute Field Ambulance, are trapped in the perimeter, treating hundreds of wounded in cellars and churchyards under constant mortar and sniper fire. Supply drops miss the shrinking perimeter, and the medics run out of morphia, plasma, and dressings. They use tablecloths for bandages and door panels for splints. The wounded lie in rows on the stone floors, some for days, and infection begins to take hold despite efforts at hygiene. The Germans allow a brief truce to evacuate some of the wounded, and the Dutch underground helps smuggle others out to the lines. But many are left behind when the survivors withdraw across the Rhine on the night of September 25th. Those captured receive care in German hospitals, where conditions are dire but the medical staff, themselves short of supplies, do what they can. The autumn of 1944 is a slog through mud and rain, the advance slowing to a crawl along the Belgian-Dutch border and the approaches to the Scheldt estuary. The fighting for Walcheren Island, flooded by Allied bombing and defended by entrenched Germans, is brutal. The assault brigades, including commandos and infantry, attack across causeways and mudflats under fire, and the wounded are evacuated by DUKW, the amphibious trucks that churn through the water and mud, their cargo holds filled with stretchers. A Duca driver named Sergeant Hodge makes 4 trips in one night, ferrying wounded from the Walcheren shore to a floating ADS on a converted barge in the Scheldt. The barge rocks in the current, lantern swinging, and the MO, a captain named Graves, works on a table bolted to the deck, cutting and sewing while the orderlies hold the patient steady. One case is a commando with a sucking chest wound, the lung collapsed, air hissing through the hole in his rib cage with each breath. Graves inserts a chest tube, a rubber hose pushed between the ribs into the pleural space, and connects it to an underwater seal, a bottle half filled with saline that allows air to escape but not re-enter. The lung re-expands, the patient breathes easier, and he is evacuated by DUKW to the mainland, and then by ambulance to the CCS. He survives, one of hundreds pulled from the Scheldt mud that November. Winter comes early in 1944, and the conditions in the forward areas are medieval. The raps are dug into frozen ground, roofed with logs and earth, lit by candles and smelling of damp wool and gangrene. The wounded arrive with trench foot, a cold injury that swells and blackens the toes and can lead to amputation if not treated. The MOs inspect feet daily, order dry socks and boot changes, but the supply of dry socks is never enough. Lice are endemic, spreading from man to man, carrying typhus, and the medical officers conduct delousing with DDT powder, dusting it down collars and into seams, a white cloud that chokes and stings, but kills the lice. Dysentery spreads through the units, a waterborne disease of diarrhea and dehydration, and the medics treat it with chalk and opium and quarantine. But the latrines are crude and the water supply suspect. The MOs are exhausted, running on Benzedrine tablets and tea, their hands cracked from cold and disinfectant, their uniforms stiff with dried blood. Some crack under the strain, sent back to base hospitals with battle exhaustion, the same diagnosis given to infantry who can no longer function. The system bends but does not break, held together by discipline, training, and a stubborn refusal to abandon the wounded. In December, the Germans launched their surprise offensive in the Ardennes, and though the main weight falls on the Americans, the British Second Army in the north is pulled into the battle, defending the Meuse crossings and providing reserves. The REMC units in the sector go on high alert, preparing for mass casualties that fortunately do not materialize in the numbers feared, but the strain is constant. The CCSs fill with American wounded evacuated north, and the British surgeons work alongside their American counterparts, sharing techniques and supplies. A tension develops over the allocation of penicillin, still in short supply, with some units hoarding and others begging. A British MO at a forward ADS trades a crate of morphia syrettes for a carton of penicillin from an American medic, a black market transaction that saves lives and goes unreported. By February 1945, the front has moved into Germany, and Operation Veritable, the assault through the Reichswald forest, begins. The forest is a nightmare of mud, mines, and artillery, the trees splintered and the ground churned to a slurry. The raps are set up in shell craters and abandoned bunkers, and the wounded are dragged out on stretchers through knee-deep mud, the bearers slipping and cursing. A rifleman from the 53rd Division steps on a shoe mine, a wooden box filled with explosive, and the blast tears off his foot at the ankle. He is found by his section, the stump tourniquet with a belt, and carried to the rap, where the MO injects morphia and sprinkles sulfa and sends him back on a jeep that bogs down twice on the way to the ADS. The jeep driver, Private Collins, digs it out with his hands, shivering and soaked, and gets the wounded man to the ADS 3 hours later. The surgeon at the ADS performs a guillotine amputation, cutting through the remaining tissue just above the site of injury, and the rifleman is evacuated to the CCS, where the stump is revised and closed a week later. He is flown to England on a Dakota, one of 20 stretcher cases loaded into the cargo hold, and arrives at a base hospital near Oxford within 24 hours of his wounding, a speed unimaginable in the previous war. The Dakota flights are the pinnacle of the evacuation chain, a system perfected over the year. The aircraft, C-47s in American nomenclature, are fitted with litter racks along the walls, stacked 3 high, each holding a stretcher. A medical orderly and a flight nurse accompany each flight, monitoring the patients during the 90-minute flight from Normandy or the Netherlands to southern England. The unpressurized cabin is cold and loud, the engines roaring, and some casualties, especially those with chest or head wounds, suffer from the altitude. But the speed of evacuation more than compensates. A soldier wounded on the Rhine can be in a British hospital within a day, receiving definitive care and beginning rehabilitation while his comrades are still advancing. The crossing of the Rhine in late March, Operation Plunder, is the largest river assault of the war, and the RAMC prepares for mass casualties. Forward surgical teams are positioned just behind the assault waves, ready to move across once the bridges are secured. The raps are established in captured German bunkers on the east bank, and the wounded are ferried back across the river by DUKW and by Bailey Bridge. The casualties are heavy on the first day, with machine gun fire and mortars raking the landing zones, but the medical chain holds. A tank crewman, burned when his Sherman bruised up after a Panzerfaust hit, is pulled from the hatch by his mates and carried to the RAP, his face and hands charred, his uniform melted to his skin. The MO cuts away what he can, applies tannic acid jelly to the burns, and administers morphia. The tannic acid is supposed to form a protective crust, but it is falling out of favor, and some units have switched to petroleum jelly and light dressings. The crewman is evacuated by DUKW, transferred to an ambulance, and reaches a CCS within 4 hours. He is treated by a burn specialist, a major who learned his trade in the London Blitz, and survives, though he will spend months in hospital and carry the scars forever. As the war moves into its final weeks, the RAMC faces a new and overwhelming challenge: the liberation of concentration camps and the influx of displaced persons. The medical units at Bergen-Belsen and other camps find thousands of dying inmates, skeletal and diseased, suffering from typhus, tuberculosis, starvation, and dysentery. The scale is beyond anything the system was designed to handle. Field hospitals are set up, staffed by RAMC personnel and volunteers, and the effort to save the survivors begins. It is slow, agonizing work, with many dying despite treatment, their bodies too wasted to recover. The RAMC doctors and nurses, hardened by years of war, are shaken by what they see. Some keep journals, recording the details, but most do not speak of it afterward. By May, the fighting is over, and the RAMC transitions to occupation duties, treating refugees, screening prisoners, and maintaining the health of the occupying forces. The forward units are disbanded or redeployed. The surgical teams return to Britain, and the great machine of evacuation and care that has sustained the British Army since D-Day begins to wind down. The statistics are staggering. Over 1 million casualties treated, hundreds of thousands evacuated, survival rates for battlefield injuries that were unimaginable in the previous war. The introduction of penicillin, the refinement of transfusion and shock management, the speed of evacuation, the skill and dedication of the doctors, nurses, orderlies, and stretcher-bearers, all combined to create a system that saved lives on a scale never before achieved. But the cost was borne by the men and women of the RAMC, who worked to exhaustion and beyond, who made impossible decisions under fire, who carried the wounded through mud and shell fire, who operated by lantern light in cellars and tents, who watched some patients live and others die, and carried the weight of both. The silence after the last surgery is a heavy thing, filled with the memory of faces and names, of wounds and blood, and the sound of breathing in the dark. They returned to civilian life, most of them, and resumed their practices and their routines, but the war stayed with them, a shadow that never entirely lifted. If you want to hear more about the medical history of the Second World War, the innovations, the people, and the impossible challenges they faced, subscribe to this channel now. There are more stories to tell, more voices to recover from the archives, and your support makes it possible to keep digging, keep researching, and keep sharing the history that matters.